Good morning, everyone. We're really glad that you could join us this morning. I'm Bethany Galbraith, and I'm joined by my colleagues Rachel Alguer, Lindsay Jader, and Benjamin Meyer. We're an interprofessional team that West Plan's asked to identify areas in need of improvement in our care for patients with heart failure. And we've entitled our presentation today, Achieving the Triple Aim for Individuals with Heart Failure, a Patient Partnership Approach. Our objectives for today will be to first present a root cause analysis identifying each gap that we found in care. We will discuss what optimal care would look like for our patients. We'll talk about the implementation of our suggested solutions, as well as any financial considerations regarding these changes. We will end using palliative care as an example to show how our changes would affect an everyday situation. Throughout our proposal, we want to keep in mind the triple aims as they are the basis of West Plan's foundation. The triple aims include improving patient experience of care, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. Throughout our proposal this morning, we will refer to a patient named Harlan to illustrate some of our points. To give you a brief overview, Harlan is a 69-year-old man with hypertension, diabetes, and grade 3 heart failure who receives care from West Plan's Central Hospital, but his ambulatory care at a non-West Plan clinic. Harlan has a wife named Margie and 2 adult children named Robert and Lisa, all of whom are very concerned about his condition. However, upon investigation of his case, we found that the doctors did not include Harlan's family in very much of the decision-making regarding treatment. Harlan has multiple chronic diseases that we believe could have been addressed early on using preventative medicine. He and his family do not seem to fully understand his condition and his treatment plans, so we found areas in need of improvement regarding patient education. Palliative care was not explained to him, so he refused it when it was offered. And over the course of Harlan's treatment, he's been prescribed many medications. However, he cannot afford them all, and he can't keep straight which medications to take when. So unfortunately, Harlan has not received the optimal patient-centered care that we want to provide to our patients here at West Plan. And keeping Harlan in mind, Lindsay will now cover the root cause analysis.
Harlan's story exemplifies the challenges and problems that we at West Plan face when trying to provide care for what we will call our part-time patients, those that receive hospital care at Central Hospital, but their ambulatory care outside of West Plan. After performing the root cause analysis, the 5 areas that we identified as issues were ineffective communication, care management disconnect, gaps in technology, inadequate preventative medicine, and limited access to care. Please refer to Appendix A, Section 1 and 2 for more details on the gap and root cause analysis. Notice in this figure how each gap, the arrow points away from patient partnership. This ultimately jeopardizes the safety of all patients that we serve at West Plan. I will now give examples of what each of these gaps entails, which will be followed by our proposed solutions, implementation plan, and cost analysis. Gaps in communication, whether between providers and patients or providers within and outside of West Plan, can cause confusion and frustration for everyone involved. This leads to ineffective, inefficient, and often costly care, putting the patient's safety at risk. Another challenge that we at West Plan face regarding communication is increasing the number of patients who have up-to-date advanced directives. The second gap identified is that of ineffective care coordination. An example of this would be if our part-time patients, such as Harlan, wanted to participate in the heart failure clinic. Our clinic, as it stands now, would assume the role of his primary care physician. This is especially concerning for our patients with comorbidities, as it increases the opportunity for adverse events. Medication mismanagement is another aspect of ineffective care coordination. If patients are receiving multiple medications from providers within and outside of West Plan, then there's an increased chance that each provider does not have an up-to-date list of the patient's actual medications. This can lead to hazardous and sometimes fatal drug-drug interactions. The third gap identified is that prevents patients from receiving optimal care is technology. Our providers have complained of it taking too many clicks to document consistently those patients with heart failure, meaning some may be misdiagnosed or undiagnosed according to their chart. Our current EMR also does not allow for easy stratification based on populations, such as those with heart failure. And lastly, patients fall through the cracks due to lack of connectivity. The three major health systems in the area, including Westplan, use the same EMR. However, we're still unable to fully access patients' charts and data from the other systems. The fourth gap identified is the weak performance of Westplan's preventative medicine programs. Take referral timing, for example. Central Hospital's heart failure clinic referrals are made only after a patient is hospitalized for health care. How is a program designed to reduce hospitalizations expected to be successful when it's implemented after hospitalization? Additionally, this practice model prevents our part-time patients, such as Harlan, from accessing the clinic unless he's hospitalized for his condition. Another concerning statistic is that only 10.2% of Westplan heart failure patients actually participate in our disease and case management program. The fifth and final gap identified is the limited access to care that many of our part-time patients are faced with. Westplan strives to produce reliable, customized, accessible, and cost-effective care for all of its patients, yet struggles to do so with those such as Harlan. Additionally, the state of Oregon has the goal of delivering health care to all members of the Oregon Health Plan or the state's Medicaid program via coordinated care organizations or CCOs. Thus, with implementation of the Affordable Care Act and the expected growth of the Oregon Medicaid population, over 400,000 beneficiaries in the next decade, these newly represented patients will not have the opportunity to seek care at Westplan. With these 5 gaps identified, we now know what challenges Westplan needs to overcome in order to provide the care that all of our patients deserve. Let's now take a look at what optimal care should look like. The first optimal care solution to be discussed is ideal communication, which Rachel will talk about now.
So there are 4 components to our communication solution. Goal sheets. Goal sheets are to help facilitate the doctor-patient relationship by opening the lines of communication. Short and long-term goals will be established, and then SBAR forms are used for a variety of purposes. Different forms can have different prompts that focus on specialty-specific issues. They make it easy to share patient information between providers in a concise and structured format. And so an advance directive, also known as a living will, it has the feature of a medical power of attorney who advocates for the patient when they aren't able to do so for themselves. A physician orders for life-sustaining treatment, or POLST, is a form that complements an advance directive and is focused more on current treatment rather than future treatment. When patients have access to their medical records, they can catch mistakes that may have been made, opting for best patient care. This leads us back to our first triple aim, improving the patient's experience of care. EMRs will be discussed in later slides. And so also in the scope of communication are family disputes. And so family conflicts can become very emotional and cause undue stress to the patients, like Harlan and everyone involved. Palliative care teams can bring in trained counselors to resolve these issues. Please refer to Appendix A, Section 7 for more information. And then next, we'll hear from Ben about coordinated care management.
So patient-centered medical home is a term that you have likely heard. The American College of Physicians defines it as a care delivery model whereby patient treatment is coordinated through the primary care physician. Therefore, the patients receive the necessary care when and where they need it. We think that this model makes a lot of sense. And by forming partnerships with patients and physicians, rather than taking over the care of patients like Harlan, we will be making a huge step into achieving the triple aim. Medication reconciliation is an interdisciplinary approach focused on achieving the triple aim. By adding pharmacists and trained pharmacy technicians to our team and utilizing their skills to go into the patient's home, take a look at all the medications that they are taking, possibly even identifying redundant or excessive medications and answering any questions, we will be decreasing confusion, relieving frustrations, and increasing safety and outcomes. For patients like Harlan, this makes a lot of sense. The medical record will then be updated, relieving confusion and frustration on the provider end as well. And I will now talk about one of our solutions to our technology problems. By analyzing the proper metrics, our data will be working for us. We will have quick access to lists of the patients who can benefit most from our care. With regards to connectivity, WestPlan can lead by example, forming data sharing partnerships with other providers in the area, preventing patients from falling through the cracks, and creating a win-win situation for everybody. If our current EMR tech company is not able to facilitate these recommendations, there are definitely companies out there who will be able to. And now Bethany will talk about another aspect of improving health of populations, that of preventative medicine.
So here we have some solutions to preventing WestPlan's preventative medicine. First, currently the referrals to the Central Hospital Heart Failure Clinic are only made after a patient has been hospitalized for heart failure. We believe that WestPlan could better serve its patients if it made this referral earlier, such as after diagnosis. We understand that referring patients earlier and possibly referring more patients would require us to expand our interprofessional staff at the heart failure clinic. We suggest adding more physicians and nurses, as well as including health educators, social workers, and nutritionists to our team. These healthcare professionals could also be part of our palliative care teams. We believe that improving diabetes care is essential in reducing the risk for heart disease, and we want to do this through increasing participation in our disease and case management program. Studies have shown that patients with diabetes are about twice as likely to develop heart disease, and currently only about 45% of WestPlan patients are receiving optimal control of their diabetes. We believe that this number is entirely too low, and we found a solution to fix it. We want to automatically enroll all of our diabetic patients in our disease and case management program and create this symptom monitoring the standard of treatment for our diabetic patients. Of course, they can always opt out of the program if they want to. However, we think that we can address this through increasing patient education. We would like a health educator to come in and talk to our diabetic patients about why this program is so important for their well-being. They'll receive physical benefits through symptom monitoring, and they can also receive financial benefits through potential reduced emergency room visits and hospital readmissions. So take our patient Harlan for an example. He has obesity, hypertension, and diabetes that we all believe could have been addressed early on through preventative medicine. Harlan's medications could have been reduced had we had him being monitored more closely throughout the course of his treatment. And we would have improved his overall care as well as reduced his risk of heart disease. By improving preventative medicine, we hope to meet the triple aim of improving the patient's experience of care, including quality and satisfaction. Now Lindsay will talk about maximum access to care.
WestPlan strives to meet the triple aim of healthcare, which means that we're concerned about chronic disease in both the individual patient and overall population. In order to improve population health, WestPlan services need to be available to as much of the community as possible. One way to do this is by implementing quarterly free clinic days to any and all community members, such as Harlan. This is a great way for people to receive preventative services for free, which can help save money for WestPlan by decreasing hospitalizations and emergency room visits. Since WestPlan is full of specialists and resources, we could also host continuing medical education courses for providers in the community. It would be especially beneficial to provide courses on how to provide effective and efficient care for those patients with heart failure and diabetes. Another way to increase access to care for our part-time patients would be by offering WestPlan insurance subscriptions to other insurers. This would allow non-WestPlan members to receive care of WestPlan services with their insurance covering the cost. Finally, as a way to increase access to our Oregon Health Plan or Medicaid patients, we are suggesting that WestPlan strongly consider becoming a coordinated care organization. According to the state of Oregon, a CCO is a network of all types of healthcare providers who have agreed to work together in their local communities to serve people who receive health coverage under the Oregon Health Plan. CCOs focus on prevention and help manage chronic diseases in the community, such as heart failure and diabetes. This helps reduce unnecessary high-cost ER visits and supports the community to adopt healthy lifestyles. thus addressing the triple aim problem of improving population health. With these proposed solutions, I'll now hand it over to Ben, who will talk about our implementation plan.
So far we have identified West Plan's challenges, and we have proposed several solutions. Now, our first priority is to form an interprofessional task force who can implement our recommendations and hire the appropriate personnel. This will need to be customized to the needs of each department, just as we customize our care for our patients. We will also monitor the progress and reassess goals along the way. And as a not-for-profit enterprise that has chosen to participate in population health management, our efforts must reduce costs, be self-sustaining, and produce a positive return on investment. By following our recommendations, we can achieve all of these goals. Research consistently shows a strong return on investment for heart failure care management, most from decrease in hospitalizations. One particular study shows that we could be saving up to $536 per patient per month at 1,644 unique individual patients for heart failure in our hospital last year. We could be saving up to $881,000 per month if all of this was operating at maximum potential. Subscriptions to other insurers and providers will also increase our revenue. And we are currently operating on 89 cents on the dollar compared to other healthcare organizations in our area. Becoming a CCO will provide us with a global budget and offer us the opportunity to provide healthcare the way that we know best. We will then have an opportunity to share in the savings in the end. And now that we've heard our plan, Rachel is going to give you an example of what West Plan achieving the triple aim is going to look like.
So I've heard the words palliative care a few times now, and since it isn't a household phrase yet, I'd like to explain what it is and what it means to us at West Plan. So palliative care is not a death panel, as Harlan so eloquently put it, but is actually a life panel. There are 4 components of it, and so first is that it has anyone with a chronic illness at any age and at any stage of their disease, and it can also include curative treatment. So if you refer to Appendix A, Section 14, found on page 7, you can see that while palliative care teams are growing, they're still only present in 28% of hospitals in the United States. So based off these solutions just proposed, the following are examples of how our ideas can be incorporated in Harlan's treatment. And so goal sheets and a current advance directive could help solve some of these family problems that Harlan experienced by having his wishes clearly known and documented. And so medication reconciliation is critical for Harlan because it can teach him self-management and therefore increase his safety. And EMRs also help with MedRec and allow the best care for Harlan by allowing his providers an up-to-date progress report of him and having Harlan have access to his own medical records. And then with the access to care, Harlan and Margie can have access to all of our wonderful new implementations.
So by improving communication, improving coordination of care management, technology, preventative medicine, and access to care, we hope to meet the triple aims by improving the patient's experience of care, improving population health, and reducing cost of health care. By improving this care, we hope to meet the needs of both West Plan members and non-members alike. When formulating our proposal today, we included Harlan and the triple aims to identify these core areas in need of improvement, and we hope that upon implementation, West Plan can become a standard of care for healthcare professionals. Thank you. Are there any questions?
Okay, thank you very much. I think we'll start to work down the road here in questions, but I'll give it a start. I'm kind of concerned about Harlan. You know, as I understand it, they've kind of run out of money, and he's kind of, from our perspective, difficult in terms of accessing palliative care and just family difficulties, et cetera. What do we do on the individual case, this particular case? What do you think we should be doing?
Well, it's interesting. We do have the resources available technically, and we have been saying that we've been implementing counseling and providing social services to the families for dealing with these sorts of issues. But so far we've found that it has been quite ineffective. We believe that bringing in a trained counselor or mediator who is trained to deal with these sort of issues, rather than utilizing our staff who is better suited for other areas of healthcare, we can help improve the family dynamics and increase education and increase understanding so that everybody can benefit from our care. So that would be for the family issues.
Well, we understand that they're a deeply religious family. Kind of wonder whether maybe engaging going on social network
absolutely,
or whatever it might be.
Yes. Yes, yeah, and cultural values are definitely very important to our team and to our organization. And so taking into account every individual's outlook on life and making their care on their terms is very important.
And also with the heart failure clinic, by having them not take over the primary care provider position, we're letting the actual primary care provider stay with the family who knows them better and who knows their beliefs better.
You speak a little bit more to that from the standpoint of, our hospital here, the clinic that he's going at West, really is outside of our system. How do we coordinate between West Clinic and our congestive heart failure clinic, the interactions we actually get patients like Harlan into them sooner?
And so, Bethany.
East Clinic.
Yeah.
East-West. Thank you.
Well, we hope that through improving the medical records, we could promote sharing of medical records between the different clinics. And also through having the interprofessional teams, we think that maybe there would be more people that get to know Harlan a little bit better. And so there can be more open communication when you have more people to talk to and more people that might have time to give information to the different clinics.
It might also be beneficial to implement some sort of telemedicine program where we can be in live communication with Harlan's clinic while we're at the hospital or vice versa, so people can share information more easily and in real time.
And using the patient-centered medical home concept, the patient is coming to us for a reason because we are better at treating heart failure. And so by not taking over the remainder of their care and working with their physician to coordinate our care with the adjunct care that they are receiving, we believe we can achieve everything they need.
I'd like for you to talk in a little more detail about your implementation plan. We know often when we add tools, people, additional resources to systems, we make them more complex. We're often limited in our ability to actually understand the depth and the root cause of any one problem. So adding things often adds complexity, especially simple things like SBAR and goal sheets, things that look like time-tested, no-brainer kind of tools can often result in unintended consequences. Can you describe for me how you're actually going to implement, what's going to come first?
Actually, if you refer to the root cause analysis in the appendix, it does have a list of implementation, priorities in the last section of that. And so we've just kind of outlined which ones can happen immediately, which ones will take a little bit more time.
And we realize that change is going to take time. It would be really nice if we could just say, this is what we need to do and have it working to full capacity right away. We realize that it's going to take a lot of time and a lot of effort, but we believe that our direction is solid and we're going in the right direction, so that with the appropriate patience and with time, we also have the organizational commitment to go in this direction. And we know that going in this direction is the right thing to do. And so, yes, we realize it's going to take a lot of time and effort, but we believe that we can do this.
I really like the fact that you identified the issue of referrals to the heart failure clinic earlier as being a potential option for improving care. I think that's really insightful. But I have some concerns. Number one is, as heart failure is less advanced, there are many more patients that actually have it. And I'm wondering about the capacity of the heart failure clinic to absorb these patients. The second issue regarding that is whether or not there's going to be some reluctance from the East Clinic with regard to referral to the heart failure clinic. Would they want to give up their patients or delegate the responsibility for managing heart failure in primary care, where many feel confident to manage more basic heart failure?
Well, to answer the first question, we know that it could put a little bit of strain on our heart failure clinic by increasing the numbers, but we think that we have the funds, as been showed in the financial side. By implementing these changes, we could be saving money, so we do have the funds to expand and hire more professionals to help take care of our patients.
And we do realize that heart failure is much more broad than what we have been offering. Of the 1.4 million West Plan patients, according to statistics in the United States, 42,000 of them actually have heart failure. And so we know that by reducing the disease progression, and we're talking about sort of the end stages here, but also providing the appropriate resources to prevent those diseases from progressing, will actually put less of a strain on our heart failure clinic in the end.
So in this case, we have some really prominent affordability problems. And as you were thinking about Harlan specifically, some of your solutions might not help him because he might not have been able to afford the buy-in for part-time patients to your insurance. And he clearly had affordability issues with his medicine. Mm-hmm. So what were your thoughts about how to help that family navigate through that particularly difficult situation?
I think if we can hire or bring on more professionals who are trained in insurance, and we can have them sit down with Harlan and his family, go over their options, because right now they don't have supplemental insurance coverage, and they don't know if they get it, will it actually help their situation. So we need someone to sit down with them, go over their finances, go over their situation completely, and then tell them and explain to them what their options are. He's currently on Medicare, but do they still qualify for Medicaid? With the expansion of the Affordable Care Act, maybe they now qualify for that, and that would give him more access to care and more funds or more availability to access our programs.
And then with those, if we can bring in a diabetic educator, that could help with a lot of different things if he's actually managing his blood sugar and doing his nutritionist stuff so that he might not need as many of the medications that he's currently on.
As Lindsay spoke to with the expansion of the Affordable Care Act in Oregon, we're quite fortunate to be in the state of Oregon, and so is Harlan, because we used to have our Medicaid level set at 100% of the federal poverty level. And now it's increasing up to 138% of the federal poverty level. For patients like Harlan on a very fixed income, he could very well qualify for programs like these.
Last question.
Yes, Benjamin, you talked about that you feel you have the wherewithal to accomplish your recommendations. I'm struck by this idea that there's this huge difference between knowing what to do and getting it done. And so I'm struck by the complex nature of the issue, and then your solution seems very logical. And so I'm curious what kind of barriers you anticipate when you start to go after this, and how do you order the goods so that you kind of get the first thing first, and so that you can get to that ultimate solution, the implementation side of this, I guess.
Yeah, I'll speak to that real quick, and then the rest of the team can also. So we realized that we have been doing things this way for a long time. All the staff that we have is used to doing things in one particular way, and it's going to take a lot of training, a lot of convincing to get everybody on the same page. I don't believe that everybody's going to be on the same page as us right away, but I believe that if we show that we're doing this for all of the right reasons, and that we lead by example in what we are doing as the leadership of this organization, I believe everybody else will follow.
I think it would also be important for implementation strategy to sit down with all of West Plan and go through and get everyone's take on what is most important for them to implement right away, what can take time, and then as Ben had mentioned earlier, also like constantly monitoring, reassessing, and then adjusting our goals as we go along. Nothing is concrete, everything changes, so we just need to be able to allow ourselves to be flexible in that nature so that we can get things done when we need it, as we need it, and as resources allow.
All right, thank you very much.
Thank you very much.
Thank
We
you.
appreciate
Thank you.
your advice.
Thank you.